Welcome back to the deep dive. So if you're in medicine or you're creating diagnostic content, you know that pretty much every single big clinical decision, chemotherapy, surgery, it all really begins with one thing, the surgical pathology report.
It's the absolute foundation, yeah.
Yeah.
And historically, so much of this was learned on the job.
Right.
The protocols for how to handle a specimen, how to cut it, it was all sort of an oral tradition.
That's a great way to put it.
Yeah, and thankfully that's been formalized now into these systematic manuals, and they are just gold because they standardize everything and, they minimize error.
So our mission today is pretty straightforward. We're going to give you a comprehensive, structured summary of those core principles: specimen handling, diagnosis, reporting.
The essentials.
Exactly. Think of this as the key guide to what happens the second that tissue leaves the operating room. Okay, so let's jump right in. The very first step, the pre-analytic phase. We're talking about handling and fixation. The moment that specimen is out, you're in a race against the clock, a race against autolysis.
That race is everything. I mean, it's not an exaggeration. Autolysis, which is basically the cells digesting themselves.
Right.
It starts instantly. And if you delay fixation or you do it wrong, you've fundamentally compromised the material. We see this all the time with breast cancer.
How so?
Well, if there's a long delay before fixation, the immunoreactivity for really critical markers like the ER and PR receptors, it just fades.
And if that happened?
You could get a false negative.
Yeah.
You could end up under-treating a patient because of a pre-analytic error. It's that serious.
So speed and the right chemicals are non-negotiable. What's the standard, the go-to fixative?
It's 10% neutral buffered formalin. That's the workhorse. It preserves tissue really well, it's compatible with almost everything we do, and it's generally safe.
But there's always a but.
There's always a but. You have to know when formalin is not enough, or even when it's the wrong choice entirely.
So that's where the specialized fixatives come in. Can you walk us through a couple of those alternatives?
Absolutely. So let's say you have a tiny GI biopsy. You need really, really sharp detail to see the cells. Sometimes you'll use something called Boone's solution.
Boone's.
Yeah, it makes the H&E stain look beautiful. The cytology just pops. The problem is it doesn't penetrate very well, so it's bad for big samples. And if you leave the tissue in it for more than a day,
What happens?
it gets rock hard, super brittle. Trying to cut a section from it is a nightmare.
Okay, so what's another one?
Then you have Zenker's fixative. Now, this one has mercury in it, so you're thinking, why would anyone use that today?
Right, with all the disposal issues.
Exactly. But for some things, like a bone marrow biopsy, it's just superior. The cytologic detail is incredible, and it also decalcifies the bone a bit. But yeah, major downsides. It dissolves iron, which you might need to see, and the mercury means special disposal, so not for everyday use.
This specificity is incredible. But what about when you can't fix the tissue at all? When do you absolutely need it fresh?
You need it fresh when you need living cells. Simple as that. So cytogenetics, for instance.
Extending the chromosome.
Exactly. You need dividing cells. You see this with lymphomas, sarcomas. You're looking for a specific translocation that tells you the diagnosis. Formalin would just kill everything.
Makes sense.
Same for flow cytometry. You're sorting cells based on surface markers, usually for lymphomas. Again, you need fresh, viable tissue for that.
And there's a really interesting chemical exception, too, for a super common condition: gout.
Yes. This is maybe the one that's easiest to get wrong, and it's a classic exam question.
Oh, okay.
With gout, you are looking for uric acid crystals. The thing is, uric acid dissolves in water. And what is 10% formalin? It's 90% water.
Oh, no.
Oh, yeah. You drop that specimen in formalin, poof, the crystals are gone, diagnosis lost.
Because what's the fix?
It has to go into 100% ethanol, a completely water-free or an aqueous process. It just shows how incredibly nuanced this first step has to be.
That gout example really drives it home. Okay, so we've got the fixation right. Now the specimen is on the bench. We're moving into grossing, orientation, and diligence.
Right. So we're going from chemistry to spatial awareness and documentation. And orientation is just, it's everything, especially in cancer surgery.
They have to know where the margins are.
You have to know exactly where every margin is in relation to the patient's body. So we teach this little trick. We tell everyone to visualize the specimen as a six-sided box.
No matter the shape.
No matter the shape. And to make that work, the surgeon has to put two sutures on it at right angles. So maybe a long suture on top for superior and a short one on the side for lateral.
And if you have those two,
You can definitively identify the other 4 sides. If you don't have that, it's just guesswork. And that's not good enough when you're talking about re-excision or radiation.
then there's the gross description itself. The source emphasizes that this is a permanent legal document. And it talks about language, like saying red-brown instead of reddish. Why is that so critical?
It's all about objectivity and precision. Reddish is subjective. What does that even mean? Red-brown is a specific descriptor.
Right.
A pathologist pulling that report 5 years from now needs data, not interpretation.
Yeah.
Also, some colors are fleeting. The deep red of an inflammatory carcinoma, for example, that's from blood flow. It's gone once the specimen is fixed. You have to document it immediately.
And this ties into avoiding diagnostic terms in the gross description, right?
Oh, absolutely. This is a huge pitfall for trainees. Your job is to describe what you see, not what you think it is. So you say firm, white, stellate mass. You don't say carcinoma.
Or soft, friable tissue instead of...
Instead of necrotic tumor. Right, necrosis is a microscopic diagnosis. Describing it as necrotic in the gross is a diagnostic leap, and it could be wrong and misleading. You have to maintain that rigid distinction.
Okay, let's talk about diligence, specifically the hunt for lymph nodes.
Ah, yes, the lymph node search. This is just a core pillar of quality assurance in pathology. In a big colon or breast resection, if you find fewer nodes than you expect, that's an immediate red flag.
And why is that search so important?
Sometimes it's how you find an occult cancer. You find a positive node in a specimen that was supposedly benign. It happens.
So if the node count is low, what's the thought process?
There are basically 4 possibilities. 1, pathology messed up. The prosector just missed them. 2, patient factors like their age or previous surgery. 3, treatment factors, chemo or radiation can shrink nodes. Or 4, surgical factors, maybe it was a small sample,
And the pathologist's job is?
is to eliminate number 1. You have to prove it wasn't a prosector error. So you go back to the specimen, you slice it thinner, maybe use a clearing solution, and you document everything. You have to write in the report, a diligent search was performed. If you don't, you haven't closed that quality loop.
That systematic approach is so important. All right, let's shift gears to a really high-pressure situation. Intraoperative consultation, the frozen section.
Yep, the FS.
In that tiny window of time, what are you and the surgeon actually trying to accomplish?
There are 3 main goals. First, and most obviously, a rapid diagnosis to guide the surgery. Are the margins clear? Should we close the patient?
Okay.
Second, it's about triaging the tissue. We need to make sure we save fresh material for those special studies we just talked about, if needed. And third, sometimes it's as simple as confirming you're in the right spot, that you actually have the lesion you're trying to sample.
But with that speed comes a lot of risk.
Yeah.
Frozen sections are not perfect.
Not at all. And it's important to know why. When a frozen section diagnosis is wrong, about 40% of the time it's sampling error. We just didn't freeze the right piece. Another 40% is interpretive error. The pathologist misread the slide. And the last bit is usually technical problems.
Speaking of technical issues, the source had this really surprising, almost shocking detail about safety in the lab.
Oh, I know exactly what you're talking about. The aerosol coolants.
Yes. Tell us about that.
So historically, to freeze the tissue block really fast, people would use these aerosolized gas sprays like Freon.
Okay.
What they found was that this practice was creating these microscopic aerosols of tissue, and it was actually linked to lab staff converting to positive tuberculin skin tests.
Wow. So they were aerosolizing TB.
Potentially, yes. That risk, plus the fact that Freon is terrible for the ozone layer, is why that practice is just... It's completely discouraged now. It's a great reminder of how even small technical steps have these huge safety implications.
That's incredible. And it leads perfectly into the rule of deferral, knowing when to just pause.
The rule is very simple. When in doubt, defer. It is always safer to wait for the permanent sections than to make a guess that could lead to the wrong surgery.
Can you give an example?
Sure. Follicular neoplasms of the thyroid. The difference between a benign adenoma and a carcinoma can be incredibly subtle, impossible to see on a frozen. We actually have data showing that in those cases, doing a frozen section only led to the correct change in surgery about 3% of the time.
And the other side.
But it led to an incorrect or unnecessary procedure 5% of the time. So the risk is actually higher than the benefit. You defer.
That is wise counsel. Okay, let's move on. We're expanding the toolkit now beyond the H&E stain into immunohistochemistry, IHC, and molecular studies.
Right. And IHC is a pillar of modern diagnosis, but it's often misunderstood.
How so?
People tend to think of it as a simple positive or negative test, but it's not. The key thing to remember is that you should almost never rely on a single marker.
Why not?
Because markers can cross-react, tissue preservation isn't always perfect, so IHC is most powerful when you use a panel of markers to build an immunochemical profile. You look at the whole pattern.
And that demands really strict quality control. What should people be looking for on an IHC slide to make sure it's valid?
An internal positive control is non-negotiable, and while some labs use Vimentin, a better one is often smooth muscle alpha-actin, or SMA.
And why is that one better?
Because it has a very specific distribution. It's reliably found in the smooth muscle of blood vessels and in parasites in almost any tissue. So if the SMA isn't lighting up in those specific spots, you know there's a problem with the whole run. The test failed.
What about false positives? How do you recognize those?
You have to be ruthless about ignoring non-specific staining. So any diffuse background color, any stain that's pooled up on the edge of the tissue, that's called edge artifact, or any staining in crushed or dead cells.
Right.
With one exception, keratin can persist in necrotic cells,
Right.
but the other crucial one is location. For hormone receptors like ER and PR, they must be in the nucleus. If you see brown stain in the cytoplasm, that is not a positive result. It's just non-specific garbage.
So let's make the panel concept practical. The CK7-CK20 combination is a classic example.
It's the perfect example. Just those two markers can split most carcinomas of unknown origin into 4 big buckets, which immediately narrows your differential diagnosis.
For instance,
Well, if a tumor is CK7 positive but CK20 negative, you start thinking lung, breast, ovary. If it's the reverse CK7 negative, CK20 positive, you should be thinking very strongly about a colorectal primary. It's an incredibly powerful first step.
and this is really where pathology directly drives therapy today, isn't it?
This is the entire point of modern pathology. We're not just naming diseases anymore. We're providing a treatment roadmap.
Like with HER2 and breast cancer.
Exactly. Identifying HER2 neuropositivity is mandatory. It tells you the patient will likely respond to trastuzumab, to Herceptin, or in GISTs, those gastrointestinal stromal tumors, finding a CD117 or a PDGFRA mutation means the patient is a candidate for imatinib.
Gleevec.
Gleevec, yeah, it's precision medicine. In colon cancer, something like 82% of them overexpress EGFR, which guides the use of cetuximab. Even basic cytogenetics, like finding the T1122 translocation in Ewing sarcoma or isochromosome 12p in most germ cell tumors. These aren't just curiosities, they are critical, treatable targets.
It really makes the lab central to the entire patient journey. Let's move to our final segment then. Reporting and minimizing errors. What makes a pathology report complete?
Okay, so a complete report needs to be, well, complete and transparent. You need the unique specimen number, all the dates, the clinical history, any notes from the OR consult,
Do basics.
the basics, but also, critically, a gross description that details the disposition of all the tissue. You have to document what was submitted for slides, what was saved fresh for other studies, what was archived. Total transparency.
And then there's communication, especially for those hard stop results.
Oh yeah, immediate communication is vital. There are some findings that you just can't let sit in a report.
Like what?
Like finding crescents in over half the glomeruli on a kidney biopsy. That means rapidly progressive kidney failure, and the patient needs immunosuppression now. Or finding acid-fast bacilli, or any invasive organism in a patient who's immunocompromised. You pick up the phone, period.
We talked about how important the gross exam is. It sounds like failures there are still a major source of error.
A persistent one, yes. One study found that inadequate gross examination was the cause of major discrepancies in 5% of breast cancer cases. 5%.
That's huge.
It is. The way to fix it is, frankly, more supervision for less experienced prosectors on big, complicated cases like mastectomies. And we have to use technology like specimen x-rays to find those tiny little microcalcifications or clips so we know we're sampling the right area.
And lastly, what about when new information comes in after the report is signed out? The addendum.
Addendums are tricky. They're necessary, but they carry this huge risk of being missed by a busy clinician.
Right.
So the rule is this. You should never put critical diagnosis-changing information only in an addendum. If your molecular results come back and they completely change the diagnosis or the prognosis, you have a responsibility to directly contact the clinician to make sure they've seen it.
What an incredible survey of this entire process. It's really clear that surgical pathology is this blend of meticulous protocol, deep scientific knowledge, and really high-stakes clinical judgment.
It's all of those things.
And if you're a learner, these are the checks and balances that make sure the diagnosis you finally sign out is as close to perfect as possible.
That's right.
So to wrap this up and help solidify what we've covered, let's leave you with a quick review exercise.
Okay, so imagine a surgeon sends you a fresh, unfixed lymph node from a young patient. They suspect lymphoma. Based on what we discussed today, list 3 critical steps your team has to take immediately before any of that tissue goes into formalin.
Think about all those special tests that need living cells or unique handling.
And as a final thought, as we move more and more into this world of molecular testing and targeted therapy, the pathologist's role is really shifting. It's moving upstream. We're not just classifying disease anymore. We are becoming the gatekeepers who optimize the tissue itself to make sure it can yield the molecular data that's needed to guide truly individualized therapy. That optimization, that's the new frontier.